with a lot of fluids. Some doctors, they prefer to use bicarbonate drips. My recommendation is don't use it because the evidence is not very strong compared to normal saline. You just give them a lot of normal saline to try to force diuresis and to try to make those kidneys, get rid of the potassium and the phosphorus and everything else that's producing like crazy. Okay, so that's the inpatient management of hyperkalemia. The outpatient management, the mainstay is education about potassium. So make sure you know your potassium. And the recommendation for patients with a potassium restricted diet, how much is it? Do you guys remember? For sodium is 12 to 2,000, right? Remember 2,000 milligrams we talk about? How much is for potassium if you need to restrict potassium on someone? You guys remember? 1,500. So if your patient needs to be on a potassium restricted diet and your patient is dependable, is a little sophisticated, and they go and read the labels, so the recommendation is they should not exceed more than 1,500 milli equivalents of potassium in a 24-hour period. So that's the mainstay. So for those patients that are doing a good job and you still want them on an ACE inhibitor and there's no way to bring down the potassium, and I'm talking about if your patient is listening. Let me go back a little bit. If your patient is listening and doing whatever he's supposed to do, most likely you won't need to use any of these medications. But if you have to, the available options are Kaiser. I'm not a big fan, but some doctors prescribe it, and patients have diarrhea, and it's very uncomfortable. If you go out, you can have explosive diarrhea and have accidents all over the place. And there are a couple of new agents that are FDA approved. One of them is called Permanente, I think is this. I forget what the generic is. Let me look it up. Can you guys look it up with the?
Yeah. Sorry.
Oh, you have it here? Yeah. So that's a resin as well. It's no problem. No, that's for bone. That's that's Permanente is for bone. It's I remember that name. Veltasa, yeah, Permanente, yeah. So, this is the same lady that visited me, Tracy. Yeah. So, this medication, it's. Do you have any samples, Dr. Ben-Zur? Have they given you any samples? So it's relatively new, right? So, supposedly in clinical studies, the criticism that the studies received for this agent is that none of the patients were formally educated about low potassium diet. So they just told them you're gonna take this and you're not gonna take anything. And they did show that the patients, while they were taking it, it was associated with a sustained drop in the potassium. I think the data is here.
What's the mechanism of action?
It's binding. It's the same thing as Kaiser, but I think it binds in a different level. Let me just look it up.
You still have to worry about sodium retention?
You still have to worry. That's one of the problems. In Kaiser, I forgot to mention, Kaiser, one of the problems why doctors are very much against using it chronically is because it's sodium. It's like you're giving sodium to your patients. You're talking about eliminating sodium and you're prescribing sodium to your patients. Permanente.
That's one of the problems with heart failure patients who have hyperkalemia is, sometimes doctors give case like that, so they have to worsen because you're exchanging one for another.
Yeah, it's a cationic polymer. It's the same. Binds intestinal potassium, lowering serum potassium. It can be associated with low magnesium, and let me see what other black box warnings. There's another one. I don't know the name of it. If you give me a minute, I can look it up on UpToDate.
So we need to talk about electrolytes and acid-base stuff because that's the real.
Okay. All right. So let's move on with the slides then. Same precautions: GI obstruction, severe constipation, fecal impaction, and GI motility disorder. These medications are not to be used. Always remember that. And sometimes, like a post-surgical patient, if your patient has a lot of potassium, if you're in the inpatient setting and you're actually studying someone with high potassium, you want to make sure that this guy is not, one of the organs is not dying from somewhere. and I'm saying it very in a colloquial way, is make sure that you rule out rhabdo, make sure you rule out like intestinal, like mesenteric ischemia, before you jump and you start doing your automatic stuff. Okay, so let's see. It's computed. Is it working? Okay. All right, let me just put it here.
You want to sit down?
No, I'm good. I'm good.
Well, we have
I'm good.
We can be your button pusher.
I'm gonna have my computer here so I can torture you guys.
Okay.
Okay. Okay, so this is one of the most annoying topics in medical school. Yeah, and there's a lot of different ways of torturing people with this. My job is to make sure that when you that when you guys when you're a resident, when you're an intern, that you already do the homework of when you're admitting someone, you're gonna understand what is the primary acid base, what is the secondary, there is a gap or not. And if you do it methodically, you do the same approach, you're going to do very well and you're going to impress your attendings, because very few residents and interns, they get into the detail about the coexisting acid-base disorders. And if you do the exercise, you'll be surprised, because a lot of the patients, they present with coexisting acid base, not just whatever you think, like bicarbonate is low. Yeah, bicarbonate is low, but you can also be dealing with a respiratory alkalosis, right? So if you guys look for the internal consistency, you look at the bicarb on the Chem7, and you make sure that it matches with the bicarb on the blood gas, because that's the only way you can put a name and a last name to an acid-base disorder if you have a blood gas. If you just have a Chem7, you're doing presumptions, right? You understand the presentation, and you say like, oh, this patient probably has a metabolic acidosis from diarrhea, but you can be wrong. You can have a patient with a respiratory alkalosis and you didn't know about it. So that's the reason why you always need to do a blood gas. Okay, so basic physiology. Low bicarb could be metabolic acidosis or respiratory alkalosis, either acute or chronic. And high bicarb, it can either be metabolic alkalosis or a respiratory acidosis, right? We all agree with that?
Yeah.
Okay, so the second question that I want you guys to pay attention is, what's the pH? And that's why you need a blood gas. So then you're going to check for compensation. After you look at the pH, you're going to be confident to say, okay, this is metabolic acidosis or this is respiratory alkalosis. And then you're going to check for compensation, so you can determine the second acid-base process. So for metabolic acidosis, let me just move to, this is the slide that I sent Ramiro and he couldn't print. I'm going to email it to you guys, because we're going to use this slide. So for metabolic acidosis, roughly, if you have a 10-point change in the bicarbonate, there is an expected delta change of 10 points in the PCO2. So for each disorder, if you memorize this table, or if you cut it and you paste it somewhere in your notepad or on your phones or whatever you want to keep it handy, you're going to be able to solve every problem that I'm going to present you with. Okay, so we're going to be going back and forth. I wanted to give you, or maybe you can take pictures. Why don't you guys take a picture with your phones so you can do the exercises? That way we don't have to go back and forth. Ready?
Thank you.
Okay. Okay. So for metabolic acidosis with bicarb less than 10, we recommend that you guys, what is the name of this formula? A Winter's formula, yeah. So it's 1.5 times bicarb plus 8 plus minus 2. Okay. So then you check the anion gap, and that way you determine if there is a third acid-base disorder. So let me stop there and let me summarize. the first thing you look is at the bicarb, right? So that tells you whether or not it's low or high, and we can divide it up into metabolic alkalosis. Metabolic acidosis or respiratory alkalosis are the other two. Then the second thing you look is at the pH, and that's how you're able to give the first name to your acid-base disorder. Then the next thing you do is you check for compensation. That way you know if there is a second acid-base disorder. And then the third thing you do, or the fourth thing you do, is to check your anion gap, just to determine the third acid-base process. Okay? So this is the anion gap. You know, we have anions and we have cations, and we cannot measure all of them, so we just presume that they're there. And do you guys remember what is the normal anion gap? 8 to 12, yeah, 10 to 12. Some textbook says 8, 10 to 12. Yeah, so 12 is normal. So if you have a high anion gap, then the differential is this big. If you have a low anion gap, the differential is this big, but we're not gonna get into that. The purpose of this talk is to make it easy on. So this is the mud piles that you guys remember from med school. Yeah, so the mud piles have like 3 more things that I didn't include there because I want to keep it simple. Like one of them is the more recently recognized as the acetaminophen induced metabolic acidosis for those ladies, like chronic ladies, elderly ladies are using from Tylenol chronically. They deplete glutathione and they actually develop a condition called pyroglutamate acidemia, but that's not going to be on your boards. If you remember your mud piles, you're going to be fine. So methanol, uremia, DKA, paraldehyde, iron, INH infections, lactic acidosis, ethylene glycol, and salicylates. So, and when you have a low anion gap, then it's because you have a lot of cations. And if you have a low anion gap on your boards, they're going to ask you about multiple myeloma. So remember that, because multiple myeloma is one of those diseases that are like a board favorite. Let me stop there, and this is unrelated to acid base. Multiple myeloma, they will give you a question on your boards where they give you a person with anemia, some degree of renal insufficiency, and bone pain. And they may show you pictures of the lytic lesions. They may not show you those pictures. And they're going to show you a UA when they actually don't have any protein in the UA. But when they measure the UA, the patient has a lot of protein. So we call that, in nephrology, we call that the mismatch of proteinuria. And the reason being is because when you do a dipstick, the dipstick doesn't pick up non-albumin proteins. It only picks up albumin proteins. So always remember that. And remember, multiple myeloma, they're paraproteins, they're not albumin. So the only way you measure them is if you run the sulfacylic acid assay. That is usually done when you measure either a 24-hour urine protein or when you do a spot urine for protein creatinine ratio. So that's the reason why if you get your board question, you pay attention at the UA, it says no protein on the dipstick, and then they measure the 24-hour and the patient has like 3,000 or 4,000. That's multiple myeloma until proven otherwise. So, and the other hint is that the patients may have a very low anion gap. They may ask you that question. Okay. So these are the causes associated with, I'm going to give you guys the handout so you don't have to worry about, I have to send it to Ramiro so he can print it for you guys. But this is the high anion gap and the low anion gap. So you guys always, the low anion gap, just stick to your brain, should be like multiple myeloma. But for the high anion gap, you already got the mud piles, right? Okay. All right. So there is a measure anion gap and there is an expected, there's a measure bicarbonate, there's an expected bicarbonate. This is going to make sense when we start doing the exercise. But essentially, we all know that the normal bicarbonate is how much? 24, yeah, 24, right? And then you have to deduct the measure anion gap, and that's gonna give you the expected bicarbonate. I'm gonna guide you through steps because it's a little confusing when I show this slide. It's a little confusing. Okay. So this is to identify like a third acid-base disorder. So like this person, the measured bicarbonate was 24. Where is the 23? Some for every bicarbonate. So that's how you identify the thoracic base. Let me show you examples, and it's going to be a lot easier to do it with example. Okay, so the anion gap. These are the uses of an anion gap. We know that it's calculate how much hydrogen that came into the system. We need to assume a 1-to-1 consumption of bicarbonate by the total hydrogen, and we use it to calculate the expected bicarbonate. And we compare the expected bicarbonate to the actual bicarbonate from the Chem 7, and that's how you're able to tell whether or not there's a third acid-base disorder. And then it will make sense when we do the exercises. Okay. So let me just go. Okay, so when you have, there's another thing that we do when you have a patient with metabolic alkalosis. We measure the amount of urine chloride. When you have a patient with a urine chloride that is very low, you already know that you're dealing with some sort of GI losses, or patients with diuretic use. They may give you on your board somebody abusing diuretics, so make sure that they're going to give you a urine chloride. But when you have a patient with a urine chloride greater than 20, then you're dealing with probably a primary hyperaldo, like a mineralocorticoid excess syndromes, or patients that have severe hypokalemia. Okay, so before we start moving to the exercises, so the first thing you check is for internal consistency, right? So you look at the Chem 7 and you look at the blood gas. It's supposed to be done simultaneously. In real life, it's hard for these things to happen, especially if you're in a program where you need to do the blood gas yourself. So you need to coordinate with the lab. But like when you're gonna do real clean acid-base interpretation, you need to send simultaneously the Chem 7 with the blood gas. So that's what we call internal consistency. Then you look at the bicarb and then you narrow down to the first two possibilities. Then you check the pH and you determine the first acid-base process, right? Then you check for compensation with a picture that you guys took. We're gonna do the exercise. And then you determine if there is a second acid-base process present. And then you check the anion gap. And with the anion gap, you're gonna determine the expected bicarbonate level. And you're gonna compare the expected bicarbonate level to the actual bicarbonate to determine if there is a third acid base. And if the metabolic alkalosis is present, you need to check the urine chloride to determine whether or not this is chloride resistant or chloride sensitive, to determine the etiology and the therapy for these patients. Okay, why don't we start with you in that corner? Why don't you read that case and we'll do the exercise.
A 30-year-old female with progressive fatigue. Labs are sodium 138, potassium 5, chloride 103, bicarb 14, BUN 100, creatinine 10, and pH 7.32, CO2 20.
Okay, so first thing you look at the bicarb. What are the possibilities? Being low?
It's low, yeah, so it's either metabolic acidosis or respiratory alkalosis.
Correct. And then you look for consistency. Well, you can check consistency because I didn't give you a bicarbonate. Okay, the second thing you do is you look at the pH, right? pH is a little low.
So it's metabolic acidosis.
Very good, metabolic acidosis. The next thing that you do is to check for correction, right? You can use the Winter's formula there, if you want to. 21 plus 8 is 29.
1.5 times bicarb plus 8.
Plus 8 plus minus 2.
But is that chart also helpful that you took the picture? Is that
Yeah.
what that's for?
That's how you use it for. So, oops, sorry. Sorry. So Winter's formula is 1.5 times 14, that's 21 plus 8, 29 plus minus 2. And the PCO2 on the blood gas is 28. So it's expected, you know. So the correction is expected, right?
I'm sorry, how are you using your little cheat sheet?
For every delta change of 10 points in the bicarbonate, is expected to have a change of 10 in the bicarbonate. Okay. And this patient has it. If you take a look, the measured bicarbonate I'm sorry, the measured PCO2 is 28. So what's the normal PCO2? 40? 40, usually 40. So 10 plus minus 2, 28. So this person he has an expected bicarb of 30. So, and you measure 28, remember plus minus 2, so you're good.
Okay.
So there's no second acid-base disorder. And then what is the next thing you're going to do? You're going to measure the anion gap. What's the anion gap here? So 21, right? So 21, what is the normal anion gap? 8 to 12, right? So you're gonna deduct 12 from 21 and you're gonna get an ion 9. That means that there are 9 hydrogens there that are not being accounted for. And what is your bicarbonate, your measured bicarbonate? Right. So this person has an expected bicarbonate of 15, which is basically what we have right now. So there's no third acid-base disorder on this patient.
For the 24, the expected bicarb for the 24, where'd you get that number?
The expected,
that's the expected.
the expected bicarb is 24, right?
Oh, yeah.
So minus 9, and that's actually what we were able to deduct from the anion gap measurement. So let's go back to where it says number 4. So we all concur the anion gap is 21, right?
Mm-hmm.
So that 21 you're going to deduct 12, which is the normal anion gap, and you're going to get that 9. From that 9 you're going to take it away from the bicarb with the expected bicarbonate, which is 15. And that number needs to be consistent with the measure. You know, one is the calculated and the other one is the measure. So when you have a discrepancy between those two is when you conclude that there is a third acid-base disorder. So the measure is 14 and the calculated is 15, so you're good. You don't have a third acid-base disorder. You guys get it all, or you still? We're gonna do a lot, so I want you guys to be comfortable with this.
So we're saying that this guy has a metabolic acidosis in addition to one of the blood piles.
Yeah. So this person has an anion gap metabolic acidosis with no other you know, if you're gonna read the 3 things, it's gonna be a compensated anion gap metabolic acidosis. Period. No second or third acid-base disorder in this patient. So what do you think she has? This person, what are the possibilities?
With mud piles?
Yeah.
Metabolic acidosis.
Yeah. What are the mud piles?
Methanol, urea,
Formaldehyde.
Iron INH infections.
Mm-hmm.
L. Thank you. And ethanol glycol and salicylates.
Somebody with progressive fatigue is consistent with? Sepsis would probably give you fever, right? Chills.
Iron deficiency.
No, she probably has, what do you call it? She probably has DKA, right? It's possible. I mean, I'm not giving you a lot of information, but it's possible.
Why are you saying that?
That's how DKA patients present.
Oh, okay.
Like, I'm so tired or I'm so thirsty. They have like the polypsia, polyuria, polyphagia. All right. Everybody's on board, or you want to take a look at this slide a little bit more?
I think it's such a practicing.
You have to keep practicing, yeah. I'm telling you, it's the most annoying thing. If you do it this way, you're never going to get it wrong. Never. But you just need to do the 4 steps. That's why I think this talk is useful for students, because if you keep it consistent, you're not going to get it wrong. But so we all agree? You guys check for the compensation, then we check for the anion gap, and then we need to compare the anion gap with the measured bicarbonate. That way you deduct if there's a third acid-base disorder. Okay, why don't you help me with the second one?
A 29-year-old hypertensive male with blood pressure of 170/110. Lab sodium is 140/80. 25, potassium 2.9, chlorine's 100, bicarb's 32, blood urea nitrogen is 10, creatinine's 0.8, pH is 7.47, and PCO2 is 44.
Okay. If they give you this board question, what does this patient have? Without doing the acid base, just looking at those numbers. We went over this on Friday. On Thursday. About what syndrome? This patient. Remember what the take-home message is: the potassium is tightly regulated in the kidneys. If you have low potassium, there's got to be a reason for that. And with that kind of blood pressure and low potassium and metabolic alkalosis, he has primary hyperaldosteronism until proven otherwise. So this person probably has a mineralocorticoid excess. Okay, so let's do the exercise. So look at the bicarb first.
Bicarb's high. So we're thinking it's either metabolic alkalosis or respiratory acidosis.
Correct. Then you look at the pH.
pH is high.
Mm-hmm.
So it is metabolic alkalosis.
Correct.
And then
You take a look at the compensation.
compensation. So I guess it's up there.
It's right here. You can.
So change from the CO2. Do you go from CO2 or do you look at the bicarb?
You look at the bicarb because you're dealing with the metabolic alkalosis, right?
Oh, right. Okay.
So look at the bicarb. So for 10, it's about 7, but this person has about 8 points up because the bicarbonate is 32, normal is 24, so that's 8 points. So you would expect to see a delta change in the PCO2 5.6, and the PCO2 is 44. So it's okay, right? Remember,
I didn't catch that. I'm
Yeah.
sorry.
no problem.
That I didn't get.
No problem.
I
So,
like the Winters formula.
but Winters for metabolic acidosis.
Oh, only.
Yeah.
Okay, sorry.
Yeah, no problem. So look at the. So he already concluded it's a metabolic alkalosis. You guys are good there,
I got
right?
1 and 2. I
Okay,
lost you at the
very good. So this is the table that you guys took a picture,
Yeah.
and we're gonna analyze the delta change depending on the value. So we're dealing with metabolic alkalosis, so we're gonna look at the bicarb.
Oh, okay.
So for every 10, there's a delta change of 7. So this person has 8. The reason being, bicarbonate is 32. What is the normal bicarbonate?
24.
So 8,
18.
right?
Got it.
So the approximate delta change is about 5.6. And then we measure the PCO2 on this person is 44.
Yeah.
So we're good.
Because
Remember.
The ratio 7 to 10 is 5.6 to 8.
Right.
So you have to count.
Got it.
And then plus minus 2. Remember that plus minus 2?
Yeah.
That gives you like, like
Okay, that makes more sense. Thank you.
no problem. We all on board? You guys all fine? I'm sorry. I'm giving you my back.
So I get your chart, but how do you get that PCO2 is 45.6?
It's just if 10 changes 7, 8. How much is 8? It's like a, how do you call the little math formula? A what?
The ratio?
A ratio?
Wait, the expected PCO2 is 40, and so, and the change that's expected with the 8.
Oh,
change in
thank
that
you. Thank you.
Are we all good?
Yeah.
Okay. So what is the next thing that we do after you confirm for the second? If there's an
Yeah.
anion gap. So what is the anion gap?
45 minus 32 is 13.
There's no gap, right?
Yeah.
Okay. So therefore, there's no third acid-base disorder, right?
Okay.
You're done. You got an easy one. The next one is very hard. I'm just kidding.
Oh my gosh.
Yeah, we'll do it together. Don't worry about it. All right, go ahead with this one.
Okay. A 67-year-old man who presents with dizziness, unsteady gait, and decreased hearing.
When you read that, what do you think of?
Yeah.
On your board?
Many years.
Dizziness, unsteady.
I'm bored, right?
Well, you're gonna find out. Well, if you do, that's why if you do your acid base, you're gonna You're gonna come up with a diagnosis.
Hold on, now I want to guess.
What it is?
Okay, so let's do it step by step, like I told you guys. So the HCO2 is
It's 12 and it's supposed to be 24.
Correct.
So it's lower, which means it's probably a metabolic acidosis or respiratory alkalosis.
versus respiratory alkalosis, right? So those are the two possibilities. Then you look at the pH.
And it's a little bit lower than neutral, so it would be.
Actually, pH is normal, right? Is that possible?
3.5 to 7.45.
Yeah, it's normal, right? Is that possible? Yes, it's possible. So that tells me, right before you start moving into more detail, then you think about like this person has a combined acid base, because one disorder is driving it down and the other one is driving it up. So that's why it's a little tricky. But take a look. So you go basically maybe just a metabolic acidosis. You can't really call it, but you're basically that bicarb that low, it's probably metabolic acidosis. So let's do the Winter's formula for this person.
We're in the cheat sheet way then?
Yeah, you can do the cheat sheet or you can do the Winter's formula, whatever is easier.
24 plus minus 2.
Mm-hmm. What would be the expected bicarb for that person with the Winter's formula?
Oh. So would it be 20, 28 or do you go up?
Yeah, 28, right? So and how much did we measure?
How much what?
How much is the PCO2 that?
22. So we have a difference of 6.
Right, it's a big difference, right?
Yeah, okay.
So that tells you that there is a concomitant respiratory alkalosis, right?
Yes.
Okay, so let's do it again.
Yeah.
So Winter's formula is 1.5 times the bicarbonate level. So what is the bicarbonate level that you measure? Is 12, right? So that's 18 plus 8, 26, plus minus 2.
Yeah.
So if you go either way, you still have a discrepancy with the measured PCO2. So that tells you that there is something else going on. There is also a respiratory alkalosis.
Exact.
They're not exact, and that's what we're looking for. We're comparing those two numbers and just to make sure that they actually match. So the PCO2 being 22, you know for a fact that this person is also blowing PCO2. What's the only way that we bring down the PCO2? If you're breathing really fast. They're doing or any other state that can cause respiratory alkalosis, like either sepsis, gram-negative sepsis, or liver disease, or CNS occupying lesions, PEs. There's a very long PE differential for respiratory alkalosis. Okay, so we know that the expected PCO2 should have been 28 and the measure is 22, so that concludes that this person also has a respiratory alkalosis. So this person is presenting with metabolic acidosis and a respiratory alkalosis. Now we're going to measure the anion gap. Can you measure the anion gap for me?
So we get respiratory alkalosis because the measured is below the expected?
Yeah, the measure is below the expected.
Okay.
That's when you know that you're dealing with a second acid base.
Okay.
So you're at the level of the second acid base, then we measure the anion gap. What is the anion gap on this person? It's a huge anion gap, right? So she does have an anion.
10 to 12, right?
Right, 10 to 12. The 12 is like the US. So the anion gap is 24. So that's when you actually calculate the expected bicarb, which is 24 minus 12 is 12. And that's actually consistent with the measured bicarb.
Okay.
So then you stop there. So you know that this person has an anion gap metabolic acidosis with a concomitant respiratory alkalosis. What kind of disorder gives you this with that clinical presentation?
A medication?
Yeah, which one? Tinnitus?
Yeah.
Which one is that? Salicylate toxicity. Salicylate toxicity. This happens in clinical practice. You need to inquire your patients about aspirin or salicylates. So this is classic board question. and they give you a combined acid-base disorder. They give you a metabolic acidosis, and a GAP, remember, is in the differential for the mud piles, salicylates. So mud piles combine GAP metabolic acidosis with a respiratory alkalosis. Are we all on board for this one?
Thank you. This is good.
This is good? Okay.
How would lactic acidosis differ from this? Would it not have the decreased hearing?
It will have the GAP as well. But then that's when you move on to the differential and you measure the things that you can measure, because you cannot measure it for everything. You just have to presume that this is the cause. But you measure for some things, you measure like for the lactate, you can measure for the ketones, you can measure for, you know, some of the alcohols, you can calculate the osmotic gap. That's a different formula.
So clinically, the clinical presentation, how would that differ?
It will differ with the patient with sepsis usually. Remember, lactic acidosis has two types of, has many different types, but they're divided in two big groups. One is actually from decreased tissue perfusion, like in the setting of sepsis or hypotension. But there's also another type of lactic acidosis that we see, for instance, in patients with cancer. And there is a D-lactic acidosis. They give you like patients with short gut syndromes. You cannot measure short gut syndrome. Yeah, they don't have enough gut to break down the amino acids and the carbohydrates, and they get a lot of they absorb D-lactate excessively. And these patients, after they eat carbohydrates, they get very confused, and they have a huge anion gap. So, but you cannot. There's not such a thing as a test in clinical practice to measure D-lactate. You just need to suspect it based on the labs and based on. And usually these patients, they have a history of inflammatory bowel disease or traumatic, excision of the bowel or bariatric surgery or things like that. Yeah, but yeah, it's very. So then when you know that your patient has a gap acidosis, then you need to do your homework of the mud piles. So that is a little tricky, but if you're able to say like non-gap versus gap, the patient has a gap, then you already know I need to do my mud piles, and you need to go and inquire. You need to tell the patients, ask all the questions. Have you ingested anything? Have you done this? Have you done that? What about salicylate? What about Tylenol? So that's the nice thing about nephrology is that, when I'm making career choices, rheumatology is very abstract. You have to pretty much believe the story, and probably people in basic science, they do a lot of this and they understand it. But for the clinician, like I'm a clinician, it's not as tangible as nephrology. I can pretty much, when I get a consult, I look at the labs and I understand more or less this patient has been vomiting, or maybe he's having diarrhea, or maybe there's something else going on. So that's when you do this for a while, you become very, very methodical in a way that before I see the patient, I look at the labs and I pretty much already know what the patient is going to tell me. It's kind of funny, but.
So do you sit down basically with the labs for every patient before you see them, and you basically look at these? I
look at those things, yeah.
And you kind of calculate before you see them. So every time.
Every
Even
time.
when you're internist and you're in the hospital doing your rounds? Or
no, because not everybody gets a blood gas. Like when I get a blood gas, I always do the exercise. Every time I have a blood gas, and remember, you have to look for internal consistency. So the blood gas needs to be done at the same time as the Chem 7. Yeah.
Oh,
so
okay.
yeah, because remember the lung, the changes happen within minutes.
Okay.
The kidneys, the changes happens within hours or days. And the lungs are very fast, like we blow out CO2 or we retain CO2, and it changes very quickly. Whereas the kidney, the way it participates in the acid-base balance is by holding on or dumping bicarbonate. But that's a process that doesn't happen right away.
Okay.
Yeah, so that's why it's a little, you have to always, when you get a consult, you look at the timing, like the blood gas and the Chem 7.
When do you know if, say they're not a nephrology patient, when do you know to start giving them the blood gas? Like at what point in the hospital setting would you be like, I need to do this?
Yeah, depends on the indication, but like if I suspect a mineralocorticoid excess, I do a blood gas.
Okay.
If I have a patient with severe hypertension, thinking that I'm dealing with a mineralocorticoid excess, I do a blood gas. If I have a patient with electrolyte abnormalities that I cannot explain, like hypokalemia or hyperkalemia, I do a blood gas. And pretty much everybody on a vent gets a blood gas religiously every day, pretty much, because that's the way pulmonologists make the changes, but on the vent settings. But for us nephrologists, it's more like when we are call for like let's say an RTA, renal tubular acidosis, or like a question about why is this person's bicarb low and it doesn't make any sense, then we're obligated to do this.
Okay.
So when I get a consult, I not always get a blood gas. I mean, but when I get a blood gas, it's always a good exercise. When you guys are in your residency, you're doing your internship, you will be a star if you do this kind of stuff. If you present a patient to your resident you're attending with the acid base, like first, second, and third, they're gonna love how you present those things.
Have
Okay.
you noticed any, or like, does it have to be an ABG? Because I noticed
BVG can also be done.
it's fine.
It's fine. Yeah. It's just the difference is a little bit on the PCO2. It's like 2 points.
Okay.
Yeah, but it's fine. You can do a BVG.
Okay.
Yeah, BVG is less invasive than an ABG.
What do you do with that? What's the BVG?
Venous blood gas. Instead of doing an arterial puncture, they just do a peripheral blood gas. Sometimes the RT is not available. When in teaching programs, usually the intern or the resident are doing the blood gas. Like you're doing the arterial puncture because you need to consent the patients and things. It's not like a typical phlebotomies because you can harm the patients when you do an ABG. But you can also, for practical purposes, or they don't even have to send it to the respiratory lab, because in some hospitals the BVGs go to the general lab or they go to the RT, and some hospitals are understaffed on the RT department, and sometimes you need these answers like right away.
Right.
Yeah, and another nice thing about doing an ABG is that the ABG gives you the electrolytes. Let's say that you need the electrolytes, you can just order the electrolytes in the ABG,
Okay.
but they tell you the sodium and the potassium.
Right.
I mean, if you need to like acutely manage somebody that's very critical, you get electrolytes from the ABG.
Do we see that? Sorry, we're new to
Yeah,
rotations.
no problem.
Do we see that a lot in our like internal medicine
Oh
rotations
yeah,
then?
a lot. This is like when you admit patients, this is like bread and butter. This is something you guys need to master when you go to your internship. When you do your ICU rotation, your attending is going to tell you, okay, what is the blood gas? They're gonna pimp you every single time you're presenting a critically ill patient on the vent. They're gonna ask you for the blood gas, and you need to know what you're saying. And for patients in the floor that they're not on the vent, we're less likely to have a blood gas on them unless they have a clinical scenario like the one I just described.
Okay.
Yeah, but in the critically ill setting, everybody has a blood gas. Everybody. Yeah, and they do it every day. Sometimes they do it twice a day. Sometimes every time they change the vent settings, they need to reassess, like after a few hours of being on the vent. Yeah. All right,
Thank you.
no problem. Why don't you go ahead with this one?
An acutely ill woman with a history of nausea, vomiting, admitted to lethargy. Sodium 130, potassium 2.9, chloride 85, bicarb 24, BUN 20, creatinine 1.2, pH 7.4, PCO2 41, and hydrogen 40. Well,
So let's do the exercise. So normal bicarb, normal pH. So first acid-base disorder is a mystery, right?
Okay.
So the second thing that you look is for compensation. How are you going to look for compensation? No, second look you look at the pH. It's normal.
Okay.
So who knows? 13 you look for the compensation. Who knows? So what's next?
Dear Mr. Attending, please
Would you
help
do
us.
it?
Of course.
You would, even
Yeah.
though there's no.
That this is why it's so important that you always do an anion gap. Some labs and some teaching hospitals, they always report it because there has been so many cases of patients or physicians discharging patients with sepsis or with a lactic acidosis or anion gap metabolic acidosis, that a lot of the labs are actually reporting the anion gap. They calculated it for you. Not all the hospitals do that, but some hospitals do.
So
And sepsis is heart rate greater than 90,
Uh-huh.
respiratory greater than 20,
Uh-huh.
temperature greater than 101 or less than 96.8,
Uh-huh.
my blood cell count is greater than 12,000 or less than 4,000, 10% Vance. Only reason I know that is for my first rotation last month, for family, we went and saw a patient who had Huntington's disease and to do OMM on him and to also check up on him. And every time we had to go see him, you have to check his labs to make sure he didn't have sepsis before you approached his room.
Really?
Yeah.
Yeah, and then what about the lactic? There's a lactic criteria.
Oh, I didn't get that.
Yeah,
What's the
there's a
lactic criteria?
for severe sepsis, lactate greater than 2 is severe sepsis.
Okay.
So that's why you are able to conclude that this patient is in trouble by doing the anion gap. Why don't you tell me what the anion gap is?
109.21.
That's very abnormal, right?
Yes.
very abnormal, right? If you have a gap, you better know why your patients have a gap.
Okay.
You know, sometimes chronic renal failure can give you a gap, but the other things that can give you a high gap, some of them can be killers. Some of them, if you let a patient go home with an ion gap of 21 and you don't know what the hell's going on.
I still don't really understand why that is, like why that could, I guess I'm just not really understand why that would be so terrible to send them home with that. Like what are you worried about in that?
Sepsis primarily.
Sepsis.
Yeah, let's do the exercise for this person and you'll see. So you don't know how to do the expected because there's no way of like doing the delta, but we know that there is an anion gap, 21, right?
Yeah.
So that tells you that there is metabolic acidosis, right, on this person.
Okay.
And the expected bicarb is?
15.
So it's 21 minus 12 is what, 9? 24 minus 9 is 15. And the bicarbonate, the measured bicarbonate is 24.
Mm-hmm.
So is there a third acid-base disorder?
Yes.
And how is it called? There's more bicarb than what the patient should have. That's basically what's going on. So what gives you that? Alkalosis. And why do you think she has a metabolic alkalosis?
Oh, the nausea vomiting.
She's vomiting.
Yeah.
So she's losing all the hydrogens in the emesis. So this person has an anion gap metabolic acidosis and a metabolic alkalosis. So this person is probably pretty sick. You know, who knows? Maybe she has sepsis. Maybe she has DKA. So that's the utility of doing this kind of stuff. Is like before you send out the patient. Like one of the dangerous jobs is being a hospitalist when you get called by the ER, because the ER is a very high tech. Workflow, like protocol driven specialty, where they need to make fast decisions and they involve a lot of the other doctors in the care of the patients. So sometimes they're a little uncomfortable, sometimes they make decisions and they want to release everybody home, but when they're not sure, they call an internal medicine doctor as a hospitalist. And your decision, when they do a consult, your decision is to admit the patients or send them out. If I admit this patient, I work as a hospital, once in a while I do admitting shifts. If I go see this patient and I look at those labs, a little bit of low potassium because she's been vomiting, but I don't do my exercise, I can send this patient home.
Yeah.
And she had a huge gap. So that's why, you know, you guys need to do the exercise of doing the anion gap calculation.